All right, good afternoon, everyone. My name is Dr. Eric Hung, and it's my pleasure to introduce you to GME Grand Rounds. This is a sort of a new time for us and a new approach for GME Grand Rounds, and so I wanted to first thank you for participating and do a couple of sort of general sort of remarks before we get started for our speaker today. Once again, my name is Eric Hung. I'm in our Office of Graduate Medical Education as the Director of Curricular Affairs for GME. And it's my absolute pleasure today to be able to introduce our speaker. I'm going to say a few words about Dr. Sood, and then I'm going to share a little bit of how we will go about doing Grand Rounds for today. So Dr. Sood is an Associate Clinical Professor of Pediatrics in the Division of Pediatric Hospital Medicine at UCSF. He is no stranger to UCSF, having done his residency and chief residency here with us. He cares for newborns and hospitalized children at ZSFG and also at Washington Hospital in Fremont, California. He currently serves as the immediate past chair of the Pediatrics Department at Washington Hospital and as the director of the Pediatric Global Health Clinical Scholars Pathway. He is a faculty affiliate of the UCSF Institute of Global Health Sciences and of the Health Equity and Action Leadership Fellowship, otherwise known as the HEAL Fellowship. Today, Dr. Sood is going to be talking about the very important issue of PPE, which has had a lot of attention in the COVID-19 pandemic. And Dr. Sood is going to really sort of take us through what I think is going to be sort of thinking about PPE from a lot of different angles that go beyond the kind of sensationalism and the headlines, and also the fear that many of us who are working on the front lines face. In terms of the discussion and the presentation today, I want to draw your attention to a couple of features in the webinar. Each of you has a Q&A feature that will allow you to ask questions as we go. Our intention is to be able to stop periodically at the end of each of Dr. Sood's sections to be able to answer one of those questions, and then to parking lot the other questions towards the end of the presentation, and to be able to answer many questions at the end. This will allow us both to have some engagement during the course of the presentation, but also to answer questions at the end. So please feel free to use the Q&A feature. You can also vote up and down for questions that you find particularly salient and important, and vote down for others that seem uninteresting. So without further ado, I want to thank Dr. Sood so much for being here with us in GME Grand Rounds in this new virtual format, which is going to be our new normal, and to give him a warm round of applause in welcoming him to GME Grand Rounds.
Great. Thank you so much, Eric. And thank you to Dr. Barron and the entire Graduate Medical Education Office, and Brittany as well too. I appreciate the warm introduction. My apologies about where I'm broadcasting to you live from. This is a workroom at Zuckerberg San Francisco General Hospital, where I'm currently on service. I have one trainee physically distant, but in the room with me as well too. So if she asks any questions, I'll let the group know as well too. But what I think I'll do is just dive right in. And, I'll start by, give me one sec here. There we go. I have no relevant disclosures, financial or otherwise, to share. But I will note that what I'll be presenting to you is my interpretation of the literature and the evidence. And you are more than welcome to disagree with that. I welcome a healthy discussion and healthy debate about it. And these are, again, just my personal takeaways about what the evidence is behind some of the things that are out there. And I'll say, I got into this and started looking into the evidence behind personal protective equipment because I, like many of you very early on in this pandemic, just noticed a lot of heterogeneity in terms of the types of equipment and types of protection we as healthcare providers were using locally, nationally, internationally, when coming to face potential patients with COVID-19 or patients who we were concerned may have COVID-19. And the full spectrum was being seen then. We're now, if you count November as a start, we're almost 6 months into it, and some of these questions are still there and still linger. And to me, there's danger on both ends of the spectrum, right? So if we don't use enough PPE, we are going to get sick. And when we get sick, some of us may and have died from COVID-19, and other of us have been quarantined and been pulled out of the healthcare system. and that strains the system. And it also has the potential to spread the infection to our other patients who may not be infected, to our coworkers, to our family, and to our community. So it's very important that we don the right equipment in the right way to protect ourselves, both for ourselves and our patients and our communities. But on the other side of the spectrum, there's also dangers in overuse. With that comes hoarding, comes shortages, and comes inequitable distribution. And anytime there's inequitable distribution of these scarce resources that we know are limited around the world, other healthcare providers, most likely in poor hospitals and in poor countries, won't have access to adequate amounts of PPE. And the result of that, they will get sick. They will be pulled out of the healthcare system. They will spread disease as well too. So when we talk about PPE, in my personal opinion, it's about both of these outcomes and avoiding both of them, trying to find the right path to mitigate in between the two. And I'll also note that it's, you know, from the perspective of someone currently working in a rich hospital in a rich part of the world, it's a privilege really to even be having this conversation. In other parts of the world, we don't necessarily even have, they may not necessarily even have the ability to have this type of conversation. And we're already seeing some of these effects on that side of the spectrum, right? So at the top left is an article from the New York Times earlier this month of a hospital in the Bronx being asked to use, you know, Yankee rain ponchos as a form of contact gown protection. At the bottom right is bottom left, excuse me, is an article from the Times in which they were basically highlighting how the U.S. and Europe are essentially and ostensibly diverting supplies that may have otherwise gone to Latin America and Africa as well too. And that's both in terms of personal protective equipment and in diagnostics, including viral testing media. And then finally, on the right, you know, one of the things that tipped me over into doing this literature review was if we are talking in legitimate manners while innovatively about using snorkel masks to protect us, we know that there are serious issues. So I wanted to look into it further on all those fronts. And I started my search really by starting with the international guidelines, looking at what the Centers for Disease Control and Prevention were saying, looking at what the World Health Organization was saying, and looking at their citations. And from those citations, I followed other citations and amassed a, you know, a fairly robust review of the literature that basically falls into 4 categories overall too. So on the top left are retrospective studies of SARS-CoV-1. And for better or worse, we have been through this as a world before with a viral strain that's similar to SARS-CoV-2. And there's a fair amount of retrospective data on SARS-CoV-1 that might apply in this setting. The downside of that data is it's of course all retrospective. So it was a matter of asking providers who were exposed or contracted SARS, what were you wearing? Were you wearing a mask? Were you wearing an N95 mask? How close were you to the patient? And you can see that there are potential limitations in that data, just subject to all the issues that may relate to limited recall or recall bias. On the bottom left is another category of research that I looked into, which basically, you know, highlights the fact that influenza, RSV, rhinovirus exist with enough predictability that we can do prospective studies and to find out what works best to protect us against those types of respiratory pathogens. And that may be applicable in this setting as well too. On the right side of the screen, laboratory PPE studies have been done in very unique and innovative ways that I think hold a lot of value as we seek to find the truth in this outbreak. And every day we're getting more and more data about SARS-CoV-2 and how it acts and what we can do to protect ourselves as we come across it. I'll also caveat everything by saying I will go so far as to present the evidence and what the evidence may suggest is correct, but I will not be providing any concrete infection control policy recommendations in this presentation. I think that's a little bit more of a nuanced conversation that needs to happen in a more context-specific and local manner, really looking at both the resources that are available, the resources that are anticipated, and the clinical situations at hand as well too. So with that, I'll dive right in case, Eric, are there any questions that have come across about the context or some of the bigger picture preface?
There are no questions so far in the chat, but just to, again, encourage people to put in questions as we go, and we will sort of pause periodically to answer them, and we'll have some time at the end.
Great, thanks. So contact precautions. Basically, just from a vocabulary and definition standpoint, contact precautions involve the use of a disposable gown, so single-use gown and single-use gloves to protect us against pathologic agents that are either spread directly or indirectly through physical transfer. You know, an example of direct spread would be dressing a wound that might be contaminated, or changing a patient's linens in bed that may be contaminated with feces. That's an example of direct contamination that we might come across. An indirect or fomite physical transfer would involve touching an object that an infected patient has touched and contaminated as well too. So the purpose of these gowns and gloves are to protect us against those types of transmission vectors. And in the context of COVID, I wanted to know, is this necessary? You know, does it work? And it turns out we really have a robust amount of data on this that stems back as far back as 40 years. This is a study done in the US in the early 1980s, where various groups of volunteers were exposed to an infant with respiratory syncytial virus. We'll focus right now on the group that's labeled as the touchers. And basically, this group of volunteers was not exposed to the infant directly. They never saw the child. They only touched objects that were contaminated by the child, such as crib sides, pacifiers, toys. And then, quote, the volunteers touched the surfaces and then gently rubbed the mucous membranes of their nose and eye. And so the question was very directly, is contact-based transmission a plausible way of how RSV transmits? And it was a small study, you know, so of the 10 touchers in that group, 4 were infected. And so, and the median incubation period was about 6 days or so. And so to me, at least, that shows that there's certainly plausible for contact-based transmission to occur. Over the ensuing decade, more and more data came out about contact-based transmission of respiratory viruses, and infection control policies were put into place. This is a study out of Scotland, and they found that by just wearing gowns and gloves and cohorting nursing, so no masks of any sort at all too, nosocomial rates dropped precipitously. They were as high as close to 30% at baseline prior to enacting any infection control policies, and dropped to less than 10% with the inaction or the institution of using gowns and gloves and cohorting nursing. So, you know, you can poke plenty of holes into that RSV data. First, small studies. Second, it's RSV may not relate so much as we'd like to COVID-19 or to how SARS-CoV-2 specifically transmits. And so I wanted to look a little bit further. This is a study that was done in 2010 after the SARS epidemic, looking at a member of the coronavirus family. It's called transmissible gastroenteritis virus, TGEV. And what these researchers did is they cut swaths of our clothing and materials, so swaths of our scrubs, infection control gowns, gloves, and masks, N95 masks, and infected those materials intentionally with TGEV, and then tested them at various intervals afterward to see if there was still viable virus on those materials. And in fact, there were, you know, up to even beyond 24 hours, there was still viable infectious material on our gowns and gloves. I'll just note that graph is a log scale. So as a reminder, a log of -1 basically indicates there was 10% left that was surviving at that point in time. A log of -2 would mean that there was 1% left, and a log of -3 would mean 0.1% left. So it does drop fairly precipitously as time goes on, but at a 2-hour mark, you know, if you estimate that in general most items were around 10%, that's fairly significant. And then from our collective experience with the SARS epidemic, we also know that taking action against contact-based transmission works. So this was a systematic review of retrospective case control studies done after the SARS epidemic, in which, again, they asked people who were infected, who weren't infected, were you wearing a gown? And wearing a gown was protective over the course of these 4 studies that asked that question. So a pooled estimated odds ratio on that type of work showed an odds ratio of 0.23, which essentially translates into the odds of contracting SARS were 1 to 5 if you were wearing a gown versus not wearing a gown. So we know from our experience with SARS that wearing a gown was helpful and protective. Now, with regard to SARS-CoV-2, more information is coming out again every day, but we know so far it seems to act like SARS-CoV-1 in great degree. This is a study comparing the two viruses and their viability on various materials. To my knowledge, there's been no studies testing it on clothing per se, but on stainless steel and on plastic, it acts the same and has not insignificant half-lives in terms of hours as well too. So there's reason to believe that it may be transmitted in those mechanisms as well too. And then the final piece is for something to be transmitted, it needs to get through a contact-based method, it needs to get from materials onto your hand, and then from your hand onto a susceptible mucosal surface, like your nose, your eyes, or your mouth. And some of that has been studied as well too. This was a study done in 2013 in which researchers purchased various materials and tested the transfer efficiency on those various surfaces. And by that, I mean they infected those surfaces intentionally with a virus called MS2 bacteriophage. It's a laboratory virus, and then had volunteers touch those contaminated surfaces for 10 seconds and measured how much of the virus on the contaminated surface ended up on the volunteers' fingertips. And it turns out it depends really on the type of surface. In general, non-porous surfaces, so harder surfaces, had higher rates of transfer efficiency. And for us, I think that translates a lot into our doorknobs, our faucets, our anything with stainless steel, and really anything with hard plastic has a higher rate of a transfer. And significantly lower rates on various clothing items. So cotton and polyester rates as low as 0.3% in various humidity settings as well too. So, in summary, on the contact-based side, I at least interpret the data to show that it's highly plausible that SARS-CoV-2 can be transmitted either directly onto what we're wearing or indirectly, particularly from steel or hard plastic surfaces onto us, and then therefore carries the potential that we may inoculate others or ourselves if we're not following these processes very carefully and appropriately. So it speaks to the importance of wearing the gowns and of donning and doffing appropriately and of hand hygiene. I'll pause there and just touch base with Eric if there's any questions on contact precautions specifically.
There are no questions currently in the Q&A, but I do have a question just going back to the stainless steel versus plastic in the half-life slide. And just if you could clarify for us what we're looking at, especially on the y-axis in terms of that difference.
Yes, so I'm sorry, the scale itself is in hours.
Oh, got it.
And so what these researchers did is they intentionally contaminated surfaces with a specific amount of virus, both SARS-CoV-1 and SARS-CoV-2, and looked at the half-life of viable SARS-CoV-2. And viability in general means the ability for a virus to replicate and propagate, as opposed to RT-PCR studies, which we'll go into a little bit later, that just shows the presence of RNA material.
Wonderful, thanks.
Okay. So, another sector, and this is one, as you alluded to, of ongoing emotional concern and hype, is the difference between droplet and airborne precautions. This slide just shows the ongoing dilemma on that front. So as of a week ago, nurses in Southern California were suspended for refusing to treat patients if they were not provided N95 masks. And that's happening in our state as well as around the country as well. On the top right is the current infographic from the CDC, which, I think I get what they're trying to say, but the language is a bit ambiguous, in which there is a preferred PPE, which involves the use of an N95 respirator, and an acceptable alternative, which would be a face mask. So I think that lends itself potentially to some confusion and some concern. And on the bottom right is the current standards, as apparent from the California Occupational Health and Safety Association or Administration, in which they specifically say that surgical and non-respirator face masks do not protect patients from airborne infectious disease and cannot be relied upon. So some discrepancy in terms of what our regulatory authorities are saying, some concerns on the ground made me want to look into this a little bit further as well too. And just to start with the definitions there, droplet precautions basically entail wearing a mask, typically a surgical mask or a procedural mask, that protects us from direct transit of pathogens onto our susceptible mucosa. Those pathogens tend to be large droplets that don't travel very far, but can travel to some distance, and we'll talk more about that. And that the mask prevents those from directly inoculating us. The other thing that standard face masks do is they prevent us from touching our nose and our mouth as well too. So to prevent us from auto-inoculating as well too. On the other side of the slide are airborne precautions. And those are intended to protect us from fine particles, so smaller particles that can potentially spread much further in the air and they can travel further. And it entails both environmental and provider-based precautions. So just to remind everybody, a negative pressure room is basically a room that has pressure negative relative to outside of that room. So when you open the door, air is going to flow down a pressure gradient into the room as opposed to escaping from the room. The other types of environmental controls involve ventilation strategies in which the air in that room is exchanged and circulated directly out of a building, as opposed to commingling with other ventilatory ducts as well too. And on the provider gear front, an N95 respirator basically is a respirator, when used appropriately, is fit tested, so it fits around your face appropriately. And when meeting those strict criteria, block up to 95% of very, very small particles on the order of 0.3 microns, so very small overall too. Exactly what the difference is in the droplet size between a large and a small particle varies depending on the studies that you look at, and exactly what is a safe distance also varies. You know, as I'm sure all of you have seen in nearly ubiquitous settings, the blue tape on the floor that's 6 feet apart basically comes from this one study of medical students in Hong Kong who were inadvertently exposed to SARS. These medical students were going about teaching rounds, and so each of them spent 40 minutes evaluating a patient on this particular ward. And the patient in bed 11 was later found to have SARS. And the X's and O's in this diagram depict the medical students and the patients that they were evaluating. So none of them actually evaluated the index case, but they found higher rates of infection, which are the circles, in the students who were closer to the index case versus the X's, which were students not infected. They found that there were more X's further away than they were closer to. And in general, the distance was about 2 meters between the beds. And so that's how 2 meters equals approximately 6 feet. And that's how that 6 feet number came to be. Prior to SARS, there's other data, which I can talk about if there's time, of actually a 3-foot rule that was initially instituted. But after SARS, I think people became concerned that droplet precautions may be adequate, or airborne precautions may be necessary if a particle transmits more than 6 feet. Going back just one slide for a second, exactly what a safe distance is, I think there will never be a very clear answer on that, nor should there be, because it will always depend. It will depend on the person who is infected, what they're doing at the time. Are they breathing? Are they talking? Are they shouting? Are they screaming? How much and how fast can they expel particles from their body into the air itself too? It depends on what's going on in the environment in terms of humidity and wind and airflow dynamics in any place. And it also depends on the pathogen's ability to remain alive per se and continue to infect others as well. So there's cases favoring airborne transmission when it comes down to SARS-CoV-2, and there's a case against airborne transmission at this point in time. And I'll start with the case favoring airborne transmission. And that's that we know in laboratory studies, the virus can stay alive. And I'll note that on the right is a rotating drum, an example of a rotating drum, and that's what was used in these laboratory studies. So very strict controls in terms of how these lab experiments worked, but they were able to keep SARS-CoV-2 alive with a half-life of approximately an hour in these rotating drums with a very specific temperature and humidity settings of 22 degrees Celsius and 65% humidity. And so there's concern, certainly, that small particles can stay alive and can move in the air. Furthermore, in the air around patients, viral particles have been detected. So there's a study out of Wuhan, China, in which they found SARS-CoV-2 RT-PCR in air samples of both the ICU and the general ward. And per their math, they found that the potential distance of those airborne particles to spread was up to 4 meters, so about 12 feet or so, which is certainly considerable. I'll note some caveats with that, though. One is that the study only looked at RT-PCR, so it didn't look at viability or the ability for the virus to propagate. It just looked for the presence of particles. And the study was done in mid-February to early March, and as of a full month later, no healthcare workers were infected. It doesn't comment on whether the healthcare workers all wore airborne precautions, masks of N95 grade or higher. And so there's still questions, I suppose, that are lingering after that study. And similarly, there's a study as yet not peer-reviewed yet from Omaha, Nebraska, which similarly found the presence of SARS-CoV-2 RT-PCR present in 60% of in-room air samples of patients with COVID-19. Those samples, they did test for viability, and all of those samples were negative. That may be due to some limitations of the ability to test versus then a truly false or a true negative finding itself too. So there's also some evidence out there on that front. These types of studies and other pieces of information similar to that have led some to really sound the alarm. These are folks out of Australia and China who said, we plead with the international community to acknowledge the reality that the virus spreads through the air and recommend that adequate control measures be implemented to prevent the further spread. So there are certainly folks very, very concerned about airborne transmission and the need for healthcare workers and the general public to safeguard themselves against that potential route. To go over the case against airborne transmission, per se, I'll refer back to that initial RSV study that I mentioned. There was another group of volunteers that were labeled as sitters, and these volunteers were in the room with the infected patient, just literally sitting. They weren't allowed to touch the patient. They wore gowns, gloves, but they didn't wear any type of respiratory precautions, so no masks of any sort. Of those 14 sitters, none were infected. So that's one piece that may bode well, but again, it may not be completely generalizable to our current context. More specific to SARS is data from SARS-CoV-1, and this was a retrospective study looking at about 240 individuals who were exposed, healthcare workers who were exposed to SARS-CoV-1 positive patients. They excluded any patient who was receiving a nebulized therapy, and then asked those 240 people, what were you wearing? And it turned out that about 140 of them were wearing either a surgical mask or an N95 respirator, and both were protective. So that seems to bode well on that front. The droplet precautions may be adequate. Similarly, from studies of influenza, they've also found no significant difference between the use of an N95 mask or a surgical mask to protect healthcare workers. This is a study done of nurses in Canada who are on the inpatient side, and they were randomized to either wear a surgical mask or an N95 respirator for the duration of every patient encounter over the course of an entire winter season. And at the end of that season, they found nearly identical rates of influenza in both study arms. There was no significant difference. They also did expanded respiratory viral panel testing on these volunteers and found nearly identical rates of the common coronavirus strains as well, too. So there was no significant difference between wearing an N95 mask or a surgical mask. This study was done with about 200 people in each study arm. Other studies have been done on outpatient providers that have been even bigger. So this study had 2,500 providers in each arm and found nearly the same outcome, no difference between wearing a surgical mask and an N95 respirator. And this was done in multiple outpatient settings over multiple years as well too. So fairly robust data that there doesn't seem to be much of a difference when it comes to protecting us against influenza. Now, all that said, there may be heightened concern in some clinical contexts when it comes to airborne transmission. This is a study done in the UK around the time of the H1N1 influenza outbreak. And of 10 patients with confirmed H1N1, they collected 99 air samples. Of those 99 air samples, 14 were positive for fine particles, which may have the potential to spread via airborne means. And these researchers found that there was a higher amount, proportionally speaking, of fine airborne particles during aerosol generating procedures versus not during aerosol generating procedures. And they referred to a 2009 definitional list of what an AGP was. So, intubations, bronchoscopies, respiratory airway suctioning, during those types of procedures, there were higher amounts of fine particles out there. I'll note that the adjusted odds ratio on that study was not significant, but certainly trending in a range that this may be a relevant finding overall. And then data more specific to SARS also seems to conclude that during certain clinical contexts, there's the potential for higher rates of infection. And this is a systematic review of 4 case control studies looking at the rates of contracting SARS for healthcare workers during intubations. So if you were exposed to an intubation, meaning you were the intubator or in the room at the time of an intubation, the odds ratio of contracting SARS was higher, 6.6 relative to not being exposed to that type of setting overall too. So for intubations, there may be a fair amount of robust data. For other quote unquote aerosol generating procedures, the data is far less robust. This is the study that the World Health Organization cites when they acknowledge this reality. And this is why I think many of us may notice differences in the various institutions that we work in terms of what is defined as an AGP or what precautions need to take place. I'll note that with each of these types of exposures, whether it's a nebulized treatment, high flow oxygen, chest compressions, an odds ratio of 1 basically means that the odds of contracting SARS were the same, whether you were exposed or unexposed to that. And you can see a lot of these fall in that range, and certainly all of the confidence intervals cross that range as well too. A related question is, even if the SARS-CoV-2 virus is airborne, are there ways that we can mitigate its transmission? And I think the answer to that is pretty clearly yes. This is a study done in 37 volunteers who had seasonal influenza, and they were basically told to put their face into that measuring chamber and breathe into that measuring chamber for an hour, 30 minutes regularly, coughing at specific intervals, and 30 minutes with a standard surgical mask on. And wearing that standard surgical mask on the patient reduced shedding, viral aerosol shedding, by 3.5-fold overall too. So just the simple act of putting a face mask on a patient can really mitigate the amount of aerosolized virus. And there are other ways that have been not as well studied, but exist to minimize the degree of patient excretions. On the left here is an anesthesia box or cage that is being used increasingly with regard to intubating patients in whom there's a concern for COVID-19. And then on the right is a picture of a face shield that may not minimize spread into the general air, but may minimize spread or contamination of a mask that a provider is using. And then finally on this front, there's one single but promising study specific to COVID-19. And this was done in Singapore, I believe in late February or so, in which the Singapore hospital basically encountered a patient who they thought had a bacterial pneumonia. That patient got sicker, was intubated, was mechanically ventilated, and then got better. And at the time that patient was extubated, studies were only then sent specifically looking for SARS-CoV-2, and it came back positive. And so after it was discovered that this patient had COVID-19, they went back and looked at all the healthcare providers exposed to that patient in aerosol generating procedure settings, so in fairly high acuity, high intense settings. And they found, first of all, that 100% of people were wearing some type of respiratory protection, but that 85% of them were wearing a surgical mask, not an N95 respirator. And all of them, all 41, tested both initially and 2 weeks after the onset of exposure, were negative for SARS-CoV-2 RT-PCR. So certainly that seems to bode quite well, that even a standard surgical mask may be protective. So, I conclude that section by saying, again, the use of contact and droplet precautions may be adequate. That seems to be what the evidence suggests in most clinical contexts, and that there are things we can do to decrease the load of airborne viruses. But that said, there are some situations in which additional precautions might be warranted. Routine use of an N95 respirator outside of those high-risk settings, I don't necessarily think is quite supported by our current evidence base. And then, finally, there's another related question out there. A lot of folks these days are being asked to reuse their N95 masks or to use them for a prolonged period of time. And certainly that has caused a lot of concern among many providers who are used to these being disposable objects, single use, that we use and then discard afterward. So the question at hand, or the question I wanted to ask myself was, will these masks, if we use them for a prolonged period of time, be teeming with viral particles? And in that sense, are we going to increase the propagation of disease both to ourselves, our coworkers, and our patients by using them for a long period of time? And on that front, there's fairly some good news. So one is that the mask itself, the N95 respirator, has some really beneficial intrinsic properties. First, it's composed of 3 layers, and the middle layer is such that it has electrostatic properties. And that middle layer, not the outer layer, is where most viral particles are actually deposited. It's on the order of 60% in one study of viral particles were deposited in the middle layer of the mask, not the outer layer. And the second is that the virus on that outer layer inactivates with time. I refer you back to that initial study done on a member of the coronavirus family, TGEV, in which survival past 4 hours was less than 1%. On the outer surface of an N95 mask. So extended use per se doesn't mean that a lot of virus is both going to be present or going to be present and alive on the outer surface of an N95 mask. And then finally, even if there is live virus on the outer surface, much of that may not actually end up on our hands if we touch it. Right, the outer surface of an N95 mask is generally a polyester surface, and that has very minimal transfer through physical touch overall. In one study in low humidity settings, just 0.3% of the load was detected after 10 seconds of contact. And then one additional property or concern is that if I'm wearing a mask and I cough, am I going to re-aerosolize viral particles back into the air? And this is a contraption basically developed by the National Institutes of Occupational Safety and Health to test that very theory. In that contraption, the FFR is an N95 respirator that was essentially glued onto a surface, and a cough was simulated from the inner surface of the mask to propel particles outward. And the question was, after we load that mask with a known amount of viral particles, how much of those particles are going to be propelled back outward into the air? And it turns out a very, very minimal amount. So just 0.21% of the viral load on that contaminated mask actually ended up being propagated back into the air itself. So to summarize that, it would take an infected patient to potentially propagate an infection through the use of an extended use of an N95 mask. It would take that patient's viral particles to get past the patient's mask, to get past some kind of provider shield, to land on the outer surface of the N95 mask. It would need to remain on that outer surface. It would need to survive on that outer surface. We would then need to touch the mask or cough to potentially get it out there. And then we would, of course, need to, if we touch it, we would need to inoculate ourselves or others in order to potentially propagate infection. And with each of those steps, there is a significant decrease in the potential for that infectious particle to remain alive and infectious. So, in conclusion, basically my takeaways of what the evidence suggests are that contact-based transmission is highly plausible. It seems that from all 4 categories of research, there's a potential for that to occur. And the same is true for respiratory-based transmission. And we know that SARS-CoV-2 is likely present in the air, but its ability to affect via specifically the airborne route, which are these fine particles that travel far, is currently unclear. If anything, it seems to be much more related to large droplets at this point. And then we know that the risk of viral propagation through the extended use of N95 respirators can occur, but is mitigated by a number of administrative controls. And by that, I mean masking patients, using physical barriers, face shields, and whatnot, and a number of intrinsic features of those types of masks themselves too. And I'd refer you, to your local infection control policies for further guidance on specifically what to do in specific situations. And then more broadly, again, I just want to mention that I think that there are both perils to underuse and overuse, and it's incumbent upon all of us, particularly those of us working in privileged settings, to think about the issues from both of those lenses. And that yes, COVID-19 is scary, and it's new and it's uncertain. But I'd also argue, I've been a pediatrician now for about 10 years, that a week hasn't gone by where that's been the case, where I've encountered a clinical scenario that's been new, that I haven't known what to deal with. And that the idea and concept of using past evidence to guide present day decisions still holds weight in this day and age. So I'm hopeful that this presentation is somewhat of a reminder of that as well. And with that, I'll conclude and see if there's any questions out there.
Excellent. Well, thank you so much for such a wonderful presentation. We've got a number of questions streaming in through 2 different sort of channels, so I'm going to do my best to attend to both. We have some questions coming in through the Q&A channel, and just to remind those that joined late, feel free to put questions into the Q&A that will allow us to also kind of vote up and vote down in terms of specific questions. But we also have some questions coming in through the chat feature as well. And so I will sort of take a sampling of both. Perhaps I can go back to a question first from the first part of the presentation, which is thinking about sort of contact exposure and going back to the different sort of mediums from stainless steel to paper to cotton. We had a question that came in around what the evidence was or what the data was between cotton versus paper, and if you could go either back to that slide or to talk a little bit about sort of the contact transmission of SARS-CoV-2 in those mediums.
Yes. Give me just 1 second here. I can go back to that slide. So in general, while I'm pulling up the slide, we do know that porous objects hold virus less well than non-porous objects. And both paper and cotton per se are porous objects. So they would both have a lower likelihood of having prolonged infectious material on those objects. I don't know if that addresses the question per se.
I think that it does. Thank you so much.
Okay.
Let's see. So moving on to a set of questions that cover the increased risk of infection of SARS-CoV-2 for people wearing N95s in aerosolized generating procedures like intubation. I guess the one take-home point that some people are sort of drawing is that really the evidence, as you were kind of outlining it, doesn't necessarily suggest using N95s for even aerosolized generating procedures, or could you clarify that a little bit further?
Sure, yeah. So I would say that collectively the evidence in general is poor on what is an aerosol generating procedure itself too. And therefore we are all left to kind of do our best to surmise what may be the best given the potential for infectious particles. But if we're using SARS-CoV-1 and the SARS epidemic as an example by which to make our recommendations going forward, it's hard to make concrete recommendations on that front. Apart from intubations, apart from bad mask ventilation prior to an intubation in those settings, we know from epidemiology, more so than specifically from biology, that the odds ratio of contracting SARS was higher in those contexts. Whether that is specific to an aerosol, to an airborne means, meaning a fine particle being the cause of the infection, is really unknown. It could be related to just a higher density of particles overall too. So those types of suctioning and procedures may just release much more into the air, in which a fit tested mask that completely occludes our ability to take air from outside of, from the open air, may be the reason that it's protective versus the particle size per se. And so there's a lot of open questions on that front. And to the extent that resources are available to protect us in situations that may be a little bit less clear, I think that's why certain institutions are deciding to move on that front. But really, it's quite a gray zone overall, if that makes sense.
So Hill, can I sort of follow up with that? So looking at that one study in the OR for individuals that were intubated for SARS-CoV-1, it seemed that the odds ratio was, if I remember correctly, was 6.
That's right.
And were those individuals in the OR in that aerosolized generating procedure, were they wearing N95s or surgical masks, or was it clear what PPE they were using?
That's a good question. I'm trying to recall myself. In that particular study, I'm not sure, to be honest. I'd have to go back and take a look at that one. With regard to SARS-CoV-2, there's that one study out of Singapore with that single case in which there were certainly patients using both in that particular setting, and both ended up being protective. And in that study, they specifically ensured that every participant in that study had been in that room for at least 10 minutes during that time period overall as well too. So that bodes promisingly. But to your specific question about the initial studies, that data, that odds ratio of 6 comes from it's a pooled estimate odds ratio over the course of 4 case control studies that were retrospective. And I don't recall off the top of my head the specific question about what type of precautions were in place at that time.
Great, thank you. I'm going to pivot us to other forms of PPE in terms of gowns, if that's okay. So there are some questions around doffing and sort of donning of gowns and accidental contact that can exist on sort of hands. And just what you're, in kind of reviewing the PPE literature, sort of any sort of best practices around the risk of exposure in sort of donning and doffing the same gown, and if there would be any recommended sort of periods for in some ways having a cooling off period to be able to wait a few hours before doing so to minimize the contact.
Yeah, well, I would say a number of things on that front. So one is really the best way to don and doff is to have a trained observer with you, right? To make this not punitive, not a self-test where you're trying to do things right, but to collaborate with others and to do so in a safe and effective manner with checklists and with other people watching you to make sure you're doing things properly. That's one general takeaway. And another general takeaway is to, even if you're doing everything right, to really focus on standard precautions of hand hygiene as well too. Because even if you contaminate yourself, you still need to inoculate yourself. And by that, I mean, basically touch your nose and your eyes or your mouth and get those viral particles into susceptible mucosa. And, one takeaway along that front is I think a lot of people forget about the eyes. And for us pediatricians who've treated dactyl stenosis and ophthalmologists and others, the eyes and the nose are connected. And so don't think that the eyes are separate and that you can rub your eyes or adjust your glasses without really making sure that you have great hand hygiene. Now, specific to extended use of contact isolation gowns, certainly that poses some risks, as does extended use of any materials. But as I mentioned with the isolation gowns themselves too, the more that one is able to cool off, the less active viral particles are likely to be present on that gown. So, after 2 hours, I'd have to go back specifically, and I'm happy to, send out my resources about the half-life specific to contact isolation gowns at 2 hours, but certainly at 4 hours or beyond that overall too, it was in the order of less than 1% at that time of viable viruses. It's not SARS-CoV-2, right? So we haven't studied that question specifically, but something in the coronavirus family seems to not survive very long on a contact isolation gown.
Wonderful, thank you. We have a couple of thumbs up on questions around homemade material masks. And I'm guessing that the question is around kind of your opinions about, from what you have thought about in your literature search. I'm guessing that sort of masks for the general public. From the question isn't exactly specific, but I'm guessing it's geared towards that.
Sure. Yeah. Well, I'll caveat by saying I intentionally kind of focused on the healthcare provider setting for the majority of my lit review on this front. But the little bit that I've looked into homemade masks, I appreciate the Centers for Disease Control framing around that, which is essentially that those masks will probably help in an infected person spreading viral particles, and particularly large droplets, into the air. And that's the right way to think about it. If you're wearing one, you are helping by not spreading something that you might have versus protecting yourself from others. That latter question hasn't really been well elucidated by the literature that exists so far. So we don't know if that's going to protect you per se from airborne transmission, but certainly you will be contributing to the public health goal of minimizing asymptomatic transmission, where you might have it and not know if you wear a mask.
Thank you. Next question is, so with no other droplet infectious agent, do we practice airborne precautions for an aerosolized generating procedure? Should we be practicing airborne precautions for the seasonal influenza with AGP, or is SARS-CoV-2 unique in this regard? Would that lend credence to using N95s more consistently?
Yeah, well, I would say, different institutions use N95s differently, even for influenza, even for RSV overall too. There's a couple pieces there. So one is that we still don't really know per se how much an AGP increases the risk, as I mentioned from some of those pooled estimates of odds ratios. And the second piece is when we've looked specifically at influenza and looked specifically at nurses who were involved in treating patients with nebulized therapies of influenza, it made no difference. It made no difference whether they were wearing an N95 mask or surgical mask. Both ended up contracting influenza at the end of the season at similar rates overall too.
Great. Next question is going back to sort of face shields and perhaps just elaborating a little bit more on face shields. The question is, does a face shield alone provide protection? I'm guessing alone meaning without a mask. I've seen face shields being sold for pediatric protection.
I'm not aware of literature that suggests that. That's as far as I can go in terms of an evidence base behind it. From a plausibility standpoint, I would also concur that it may afford some protection from large droplets, because to some extent that is the same thing as a surgical mask, right? It's a plastic-based protection around your nose and mouth, but it would depend on the type of face shield and if there's a lot of exposure potentially underneath that shield, where a mask would cover you, from nose to mouth a little bit more specifically. I would think a mask would protect more on that front.
Great. Next question is, I'm not sure if you're going to be able to answer this. It's probably a question that will be best answered at one of the UCSF town halls. But the question is, do we have numbers on how many healthcare workers at UCSF or in San Francisco have been affected with COVID-19? Do we have a sense of particular clinical situations that might have increased their risk?
Yeah, correct. I am unfortunately not able to answer that specific question.
And I would say for the person that asked that question, please do stay tuned for the town halls. There has been some attention here paid to that. Occupational health has been giving shared updates, and I won't misquote them, but I do think that that it is important to pay attention to it. One question that has come up in the chat has been one around how to think about these data in either in support or not in support of loosening the stay-at-home requirement as long as everyone wears a mask. And I'm guessing that that's probably more in the sort of the general public space than in the healthcare worker space. But any kind of speculations there?
Yeah, it would be speculative on that front overall too, so I hesitate to comment too deeply. I think there's certainly benefits to everyone wearing a mask, but we don't quite know very much about cloth masks. And so while theoretically they will prevent large droplets from spreading, the extent to which they can be used as one means of preventing transmission, that's helpful. But I also get concerned, frankly, with a lot of cloth masks that are homemade, that people may be uncomfortable with those masks and so may end up touching their nose and face more as they're readjusting things. And as they spread those infectious particles onto their hands, then we come into the potential for fomite-based transmission or contact-based transmission. So it's a broader question that's hard to say, if everyone wears a cloth mask, will we all be fine? I don't think the answer is going to be as straightforward as that, unfortunately.
That's great. I think we are sort of ending sort of our time. I wanted just to sort of end with one sort of question that I can help answer as the moderator, and then just a thank you to Dr. Sood. So one very important question is, how soon can this recording be made available so that we can share it with other units and divisions in our healthcare settings? And the answer to that question is that we will post this recording as well as the Q&A on the UCSF GME website under our Grand Round series. So stay tuned for that. And we will be doing that as soon as we sort of finalize the product and get it up on the website. I just want to take the last minute just to thank Dr. Sood for just a really phenomenal talk. So many of us, I think, have read in so many different ways, whether that's in the New York Times or our local newspapers, or in conversations with colleagues or in town halls. So much discussion about PPE, both in terms of the evidence, but also I think in terms of the anxiety, the fears, the concerns, the questions, and in many ways kind of the practices and policies that we should all be thinking about. I think having this talk today to be able to actually share some of the evidence around practices is just incredibly important. And as you mentioned at the beginning, this is not necessarily a policy talk, and the policy talk will be influenced in a much more nuanced way at both the kind of the local, regional and sort of national stages. But I just want to thank you for engaging with us in the evidence around this particular part of the conversation in PPE. And thank you for not only being our kind of inaugural virtual Grand Round speaker for GME Grand Rounds, but also for doing it, with such thoughtfulness and sophistication and in a very timely issue. So thank you.
Thank you very much. It's been my pleasure. Appreciate it.
All right, take care, everyone.
All right. Thank you, everybody.